Initially, Lenny had asked me to update on the alliance, or the next alliance-led ALL intergroup study, but unfortunately, as I'll show one slide, that the pharmaceutical sponsorship for that particular study was withdrawn. So in lieu of that, this is more of a what I did this summer on my vacation, so to speak, talk. So I'm going to give you an update of our last decade or so of trials that we've run through the Dana-Farber Consortium, which includes about 13 participating centers, both in the United States and Canada. And so these trials are based off our DFCI pediatric colleagues, which also have a large consortium within the United States, Canada, Puerto Rico, and elsewhere. And what we endeavored to do back in 2001, based on Wendy's retrospective analysis of the CCG and the CLGB data showing an improvement in outcomes for young adults using pediatric-based regimens, is to simply take the ongoing Dana-Farber study and just expand it and up the age limit from 18 to 50. Why 50? Well, the trial should always be younger, or at least at the age of the speaker. And so, of course, now I'm going to have to adjust that as I continue to age. So I wanted to make sure that I was, God forbid, if I were to unfortunately succumb to ALL, would be able to be enrolled on one of these trials. I no longer am eligible, which really makes me quandary a lot of things, but I won't do that right now. So anyway, these are the schemata for the trials that we've done. The first one includes induction therapy, which is a BFM base, followed by CNS prophylaxis, which still includes low dose of cranial radiation. And the weird thing that the Farber has been doing for, about 3 decades is this 20 to 30 week, here 30 week, of asparagine depletion. So this is weekly asparagine, native E. coli asparaginase with chemotherapy, followed by maintenance up to 2 years from remission. And then we'll talk about the second trial later. And so this is the first trial. And again, it's just a prolongation or an adaptation of the pediatric trial up to age 50 as opposed to 18. About 100 patients were accrued, 92 to be specific. Median age was 28, and again, it included up to 50. So we had a significant proportion of patients who were over age 30, predominantly male, white, non-Hispanic, representing of the institutions at large. About 80% were pre-B, 20% had the Philadelphia chromosome, as you can see. The CR rate was about 85%. We had 1 induction death. We now have 4-year follow-up, which includes about a 69% disease-free survival and 67% overall survival. Trying to be brief given the time. The question is, were you able to administer the drugs that you had intended? And so, you can go through a lot of fancy statistics. Donna Newberg, our statistician, went through this analysis, which is basically saying what percentage of patients who started asparaginase actually finished that 30-week period. And we had 57 had the opportunity to proceed to asparaginase, those 30-week consolidation, as I mentioned to you. 63 or 36 or 63% completed all 30 weeks, and 41 or 72% completed greater than 26 weeks, which, based on our pediatric colleagues, was associated with an improved outcome. Shockingly, the median asparaginase dose was 15,000 units per meter squared during these 30 weeks, so not a trivial dose, to say the least. And if one looks at the side effects, they're very similar to what you would see in the older adolescent study. Dr. Berry and I published a paper looking at the changes in the toxicity profile as one goes from young child to adolescent to older adolescent to young adult, and these toxicity parameters really mirror those of the older adolescent. If you look at the overall survivor based on Kaplan-Meier curves, you can see that here. It's about 67% 4-year median follow-up. Now, this includes all subtypes, B, T, as well as Philadelphia. This is the disease-free. And if you look at immunophenotype, sorry for the washed-out color at the bottom, but you can see the Philadelphia chromosome really did not fare as well. Remember, this trial was started in 2001, so imatinib was not included in the induction regimen for several years. And the T's actually outdid the B's, although you can argue that some of that may be due to the presence of the pH-like that we've already heard so much about. So then we took in 2006, we added, in spirit of, again, continuing with the next pediatric trial that my colleagues were doing and adapting that from 18 to 50, again, keeping in mind the age that I was, with incorporating high-dose methotrexate and some other consolidation regimens before, and switching the native E. coli to PEG asparaginase. We had some issues, and I'm not going to go through all the trials and tribulations. We administered the PEG asparaginase at 2,500 units per meter squared every 2 weeks, which was the label. That turned out to be untenable due to hyperbilirubinemia. We had to back it down to 2,000 and extend it every 3 weeks, and that allowed us to complete our study. Again, we enrolled another 100 patients into Farber, other centers in Boston, Utah, and some Canadian centers. Very similar demographics. About 20% were Philadelphia positive, 80% were pre-B, mostly white, non-Hispanic. Our remission rate was 90%. 20% of those patients, or 20%, went on to stem cell transplantation in first remission. Most of these were Philadelphia positive. And our 2-year overall survival, 74%. We don't have as long a follow-up. This is the Kaplan-Meier curve for the entire group with a median follow-up of 25 months. And if you compare it from the current study to the older study, it seems to be very, very similar. And this is a busy slide, but again showing that the Philadelphia chromosomes, which are these two lower curves in pink or red, really is not a favorable strategy for at least the way we're doing it currently in this paradigm. These patients were not censored for transplant. The majority of those patients that were pH positive ended up going on to transplant. T cells fared a little bit better than the Bs, although not statistically significant, as you can see in this particular Kaplan-Meier curve. So in brief, the conclusions that I can draw is the administration of a pediatric protocol, not necessarily inspired, but really a pediatric protocol, taking a 1 to 18 protocol and extending the upper limit to the age of the speaker, that is 50, was feasible, and excellent long-term results, especially in the T-ALL subgroup. I think the Philadelphia chromosome requires some rethinking. We're going to exclude it from our future studies, and I'm intrigued by the pH-like that we've heard so much about. I do think that a lot of this is based on MRD. You can identify those patients at the end of induction because they tend to be more enriched in this MRD positive group. So what's next? What was proposed was this, and this was the 10403 schema with interdigitation of 2 doses, or 2 cycles, if you will, of inotuzumab, which is a CD22 conjugated antibody, which has a really remarkable single-agent activity in the relapsed refractory population. And it was really just to take the current trial that Anjali had already presented, at least on the toxicity. Unfortunately, the support for this was withdrawn, and so we're coming up with some other ideas. This is just a work in progress, trying to take advantage of what Dr. Mulligan had just recently published and identifying these BCR-ABL-like patients and adding a TKI, whether to randomize that or not, I think is a question left for the NCI-CTEP steering committee. I do want to take the opportunity to thank my colleagues at the Dana-Farber and elsewhere, particularly my physician assistants and nurse practitioners who really do the bulk of the work, as well as the patients and their families. And Lenny, thank you for inviting me.